as bad as the afternoon sessions. Okay, so anyway, so we have majority of our practice in Guwahati is actually rhinoplasty and upper eyelid surgeries. The reason for upper eyelid surgeries more is because we get a lot of monolids. Caucasian eyelid surgeries are also there, but they're not so very often for us. So there's a difference between Caucasian and upper eyelid and Asian eyelid surgeries. But the principles of the surgeries are still the same because the layers are still the same. It's just that the location of different layers are little slight variations are there between the size, between the thickness of different layers. So that is where the anatomical differences are there. But overall, the technique is much similar. So, sorry. Just can you help me out here? Anyway, so what we've done here is we've given a short video. Okay, we've compressed the video in a slight faster format. So on an average, it takes me around about 1.5 to 2 hours to do one eyelid surgery. So eyelid surgery is not just skin removal and skin excision. Okay, you have to understand that in an eyelid, so it's playing nice now, just till he's setting up. So what you have to understand is that when you're talking about upper eyelid surgeries, you have to see all the tissues around it, the problems around it. So it could be that you have somewhere hollowness happening, somewhere you have excess fat happening, somewhere you have extra skin in your upper eyelid. So you have to see all these things before you decide to do an upper eyelid surgery. And your patient demand also. So if you've got a patient who's into the middle ages, you've got a lot of loose skin. Yeah, fine. So you've got a patient with loose skin, wherein a lot of what we call a dermatochalasis, right? So then you need to address the loose skin. But apart from the loose skin, what happens as we keep on getting older is that we lose fat. So you always remember, from the face, there is fat atrophy as well as bony resorption. So as you get older, you will have, your volume loss. So the hollowness starts to come in. So even if you do just skin excision, tighten the skin, close it up, you are still not doing a proper rejuvenation of your eyelids. So you need to identify what are the problems, and fat resection, you have to be very careful when you do fat resection in your surgeries. Because once you've cut the fat, that fat is not going to come back. So you have to be careful in your treatment planning. So don't treat eyelid surgeries as a very small, minor surgeries. I consider eyelid surgeries, even if it's under local anesthesia, as a major procedure. It takes time, and you have to be very thorough with your anatomy and your the way how you approach the tissues. Now, the first thing what I do in upper eyelid surgery is that we use radiofrequency. The reason to use radiofrequency and not electrosurgery or a knife is that it's highly vascular. So everyone knows eyelid skin, your orbicularis muscle is supplied by, just now Dr. Indraji spoke about the blood supply. So it's innervated with a lot of blood vessels from everywhere. So it bleeds a lot. So we use not knife, because knife it will bleed, and again your surgical view will not be very clear. Because even though the eye is very small, it has many layers. It has a lot of layers, and each layer is very significant when you do the surgery. Each layer has very important role to play as you do your surgery. So the reason for using radiofrequency is that the energy application is point delivery. So it only delivers energy at the point of application. So you can see here now, the first thing what we do is, I still do it even at this stage. At this point, we've done around 128 upper eyelid surgeries last year. So even at that point, I still go layer by layer. Even if I'm confident that I can go through my muscle and skin all together, I still don't do it. I still go unit by unit. So first is skin only. So you can see here, it's a thin skin. As Dr. Indraji mentioned, it's 0.2 millimeters of skin thickness. So we go very only skin. Now, two importance when you go skin only. One is that you're going layer by layer, so you have less chance of getting confused with the tissue layers. Second point is, sometimes you may not need to excise the entire muscle. It's not always necessary, because muscle is also giving a certain amount of bulk. So especially if you have a patient, older patient, who's got orbital volume loss, who's got hollowness in the eye, who's got upper eyelid hollowness. So there you will actually need the muscle bulk. So at those times, I may not cut the muscle. Normally, if I'm cutting a muscle, so what I do is, whatever is about the width of the skin that I'm going to excise, I leave around about 2 to 4 millimeter of muscle extra on the either side, and then I excise the muscle. Now when I'm done with my skin incision, you see what I did here. First thing what I did here was, I've cut the muscle here. Can you see the white layer coming on that side? Now that white layer is basically me searching for my orbital septum, because the next layer that comes after your orbicularis ocular muscle is your orbital septum. So that first incision helps me to gauge the depth of my muscle thickness, because muscle thickness will vary as per the patient, also as per your anesthesia that you've infiltrated. You infiltrate more anesthesia, there will be more bulk. You infiltrate less anesthesia, there will be less bulk. It doesn't affect your surgery or the result, but it depends on how you are injecting. So that small nick on the corner I do to find the thickness. Never do the thickness in the center of your muscle because at the center your LPS is the most active part, at the central limbus. So in case you go wrong and you go deeper and you damage your levator papillae superioris, you'll end up with ptosis and you have to repair that ptosis. So we always go from the side, and you see now the second dissection is also muscle only, layer by layer dissection, skin only and muscle only. So before this you saw me giving a depth cut on the lateral part of your eyelids to gauge the thickness. Then I did a little bit of hemostasis, because I don't want my hemostasis go into my lower eyelids, because my LPS, the orbital septum is white, it's translucent in color, the fat is yellow in color. I want them to look like that when I'm approaching that area. I don't want them to become red, okay? Because if it's red, then again you lose track of your anatomy, of your surgery, because again, your fat is important. Below the fat on the lateral side, you've also got your lacrimal gland, okay? And for a beginner, it gets really tricky to differentiate between your lacrimal gland and your lateral part of your orbital fat. So it becomes tricky. So if you have a bloody field, then you will get confused, and you don't want to damage the lacrimal gland. So that is very important. Below your fat, you also have your levator papillae superioris. So again, it's a white color structure, right? Just above that, hardly around about 10 millimeters superior, you've got your mular muscle. Again, mular muscle, pinkish in color. So you don't want to confuse all those layers. So you have to make sure that your field is bloodless and it's a layer by layer surgical plane dissection. So you can see here, we don't have much blood coming here. So now what I'm doing is that we're going through the thin orbital septum. So orbital septum, as Dr. Indrajit told, it's the extension and the continuation of your periosteum from your superior orbital margin, wherein the superior one part goes and forms the periosteum of the roof of your orbit, and the one part extends down, becomes your orbital septum. So you can see here I'm doing very careful dissection, and again this also has a little bit of vascularity, mainly on the inferior part, the orbital septum, where it fuses with the tarsus and the levator papillae superioris. So you see my incision is on the superior part of the orbital septum, not on the inferior part. So you avoid superior part incision of the orbital septum, avoid the inferior part, go towards the superior part. Once I'm done with this, then I gently tease out my fat, okay? The reason why I do this is because you have to, as I told you, eyelid surgery is not just about cutting your skin and excising fat. You need to maybe mobilize your fat to different areas. So in this case, now once I mobilize the fat, one part, what you have to take care is that the lateral fat. Now in anatomy books, most of the anatomy is based on Caucasian anatomy, okay? Or Eastern Asian anatomy. Now there are very few books on the anatomy of Indian eyelids. So Indians, as you know, we are a mixture. Okay, we've got Western migration, we've got Eastern migration, we've got Tibetan, Mongoloid side, Tibetan migration. So it's mixed up, including Dravidians from the south. So our anatomy is slightly different. So what I found is in all our cases that we have lateral fat above and superior to the lacrimal gland, which is not mentioned in anatomy books. So that is why I infiltrate towards the side. Okay, now I've taken out the fat. So I'll reduce the lateral fat max. So that is where your hooding takes place. A lot of patients in older age will come with lateral hooding. So if you don't address the fat part on the lateral part, if you purely go by the Western anatomy books, what we have, then you'll end up missing out that particular fact, and your droopiness will still remain. So, so once I've done that, so now you see here, so we've taken out the fat, cleaning up the area. Now this particular case, what I'm doing here, what I'm operating here, is also a case of grade 2 ptosis. Okay, so why I put this case specifically is because along with your upper eyelid surgery, you also need to know how to address a bit of ptosis. Okay? You may encounter some amount of ptosis. So in this case, now what I do is, once my dissection, once my whatever I have to do inside my eyelid is done, then I'll take a bite with a PDS. Now what I'm doing is, once I maintain my hemostasis, I will be marking the tarsus. So I'll be marking the superior margin of the tarsus. On an average, in Indian people, the eyelid thickness, clinically, what we found is, when we give incision, when we pull it, from the lid margin, extended lid margin, from the extended lid margin, it comes around about 15 to 18 millimeters. So that is where, and it's very easy to find. When you give traction, you use your pointed instrument like a tooth forceps or non-tooth forceps, and you poke over the cervical side. Where there is tarsus, you will find resistance. You will find like a thick tissue, almost like a cartilage. You will find that thickness. So we mark that margin, and how much ever amount of ptosis I want to correct, that amount I'll mark on the LPs. So that line is the superior margin of the tarsus, and those dots are in the levator palpebris superioris, which I'm going to now plicate. For plication, I prefer to use PDS 6O. You can use 5O also, but the reason to use PDS is that PDS will last longer. It stays longer. Okay, so it stays long enough to form scar between the overlapped levator palpebris superioris and your tarsus. Here, getting a thick bite from the tarsus is very important when you're doing a ptosis correction, because you want the tarsus, you want LPS to overlap and shorten and attach with the tarsus. Also, when you're doing this, you have to be careful of not going too deep. If you go too deep, your eye is just behind it. There's not much between you and the eye now at this point, because you've just got a tarsus, and then you've got a thin conjunctiva below it, and you've got an eyeball beneath it. So it's just maybe a millimeter or two at the max. So you have to be careful. You have to be careful when you're doing this. You cannot be callous when you're doing an eyelid surgery. So you see here, so I marked generally 3 points. Now my 3 points are, mainly I mark my central point at the central limbus. That's your pupil of the eye. So that's the central limbus. So there I mark my first point for my sutures. Then I mark on the lateral limbus, that is the lateral part of your iris, and your medial, so the medial limbus. So these are the 3 points I normally take. Sometimes I may take more depending on my requirement of the surgery, but normally these 3 are enough for my, most of my, by my experience, these 3 are more than enough for me. So once I've done the plication, so you can see here, so you can actually ask your patient, because you're doing under local anesthesia, so you can actually ask the patient to open your eyes to see how much of opening are you getting. Eyelid surgeries for beginner, I would always say do it under local anesthesia. The reason for doing it under local anesthesia is that sometimes it's really difficult to identify the levator palpebris superioris. A lot of times your orbital septum is so thick and your fat is so high that you may think that your orbital septum itself is the LPS. So in that case, you may end up taking a bite from the wrong place. A lot of times there will be, the fat is still very superior, and your orbital septum has actually merged and has become actually LPS towards the superior margin of your tarsus. So by mistake, you may end up cutting the LPS. So it's always under local anesthesia in the beginning. Why? Because once you open the eye, you can actually just hold the tissue which you think is LPS, and you ask your patient to open the eyes. You'll feel a tug back. It's a typical, like as if your instrument is getting pulled in. So that you will find. So that you have to, that's why I prefer that if you're doing an eyelid surgery, especially as a beginner, do it under local anesthesia. It's completely painless. So the closure, in me, as per my experience, I always do skin, superior border of the tarsus and the LPS. So I take skin, LPS and skin, because that gives me the confidence that my anatomy and my eyelid crease is going to stay. The reason is, when you look at the anatomy, what Dr. Indrajit told you, the orbital septum merges with the superior part of the tarsus, right? So that is where the orbital septum is creating a barrier for your fat to stay, and that is the point where your LPS is attaching on the superior border of the tarsus. That is where the tarsus can sense extension adhesions with the skin. So the skin of your eyelid is adherent to the area where you have the tarsus, right? So when you do this particular technique, where you take skin, LPS and then the skin on the other side, you're basically mimicking the anatomy. You're causing the skin to adhere to the tarsus by this particular maneuver. You're making sure that your scar that forms, you're basically hoping that a scar forms here, right? A scar collagen forms here. So you're creating a scar at the junction of your superior part of your tarsus. So that is where the scar will form, wherein it will restrict the fat from further going down. So the fat gets restricted above that. Also at that junction, you have the levator palpebris superioris, which is going to pull the eyelid in. And since you have created a stop and a scar in that junction, where that exact area where you want to have your eyelid crease, so it will give you a crease which will last you much longer. So these creases generally will not disappear. The max that can happen is that patient will keep on getting older, their skin will again keep on getting laxed, the orbital septum will continue to becoming more and more lax as age progresses, and they'll have more of a skin to skin dermatochalasis. Now this is the patient, the same surgery which we did 10 days post surgery. So you can see here he could barely open his eyes. So that was a max, he could open his eyes. He had a lot of fullness on the either side, so you can see there. And this is how it's 10 days after. So you can see he's much more comfortable, he has much more bigger opening of the eye, and it's just normal without making any effort.
Use the cursor, na, Rahul?
Oh, sorry.
Use the cursor. No, that pointer won't work.
Okay, yes, ma'am.
Use the cursor and just show exactly where he couldn't open and now where.
So you see here the opening, the aperture of the eye is so small in this case. Now, wherein after surgery, it's just 10 days post surgery, you can see the aperture is much more larger because you've shortened the LPS. So it's like an elastic in your waistband, right? It becomes loose, either you replace it or you tighten the elastic, cut it out, cut the excess, tighten it. So here we can't just change the elastic. So we need to cut and shorten the elastics. This is a Caucasian eyelid. So in Caucasian eyelid, you see, as Dr. Indrajit pointed out, the crease is higher, right? So here you see the crease is much higher. She had much asymmetry on both sides. She had a lot of hollowness. So we did a lot of lateral fat. This lateral fat was there here the lateral fat that we transposed to the center. So that's why she has this fullness here. So we use fat not to just excise, but also to re-volumize the eyelids. Then this is the typical Asian eyelid, wherein the patient wants not very shallow slanting crease, but a bit more, crease where they can put eyeliner. That's the main thing for my patients, for my younger patients, because I get younger patients a lot. So the younger patients, monolid, they complain that they cannot put eyeliner. It smudges. So that's the main complaint. They cannot put eyeliner, it smudges. So that's why we give them a slight amount of crease so that the eyeliner can stay. And you can see the softness it brings, the surgery. I'm not talking about changing ethnicity. You see, both the previous surgery and this girl, they look totally different. The eyelids are totally different. So you maintain the ethnicity. You don't want to give a very high crease on an Asian eyelid. Okay, so that you have to always keep in mind. And then we've got a rejuvenation type of eyelid surgery. Now this is the one which most of the Indian practitioners will get. So here what we do is you have to identify the hollowness. See, she's got a hollowness here, she's got a lot of skin excess, she's got droopy skin excess here, she's got nasal fat pad coming out. So she's got nasal fat pad excess on the medial part, she's got hollowness in the central part. So what I'll be doing here is I'll take out the fat from the lateral part, I'll transpose it with this and suture it to the orbital periosteum towards the center. I'll take the nasal fat, I'll suture it up on the orbital periosteum again on the center towards the medial part. So I'll re-volumize the entire part instead of cutting the fat. And you can see here, this is her after 4 months, and you can see that there's no hollowness on top. She's got a nice crease. She looks much more younger. She probably looks around 15 years younger by just looking at her eyelids. So it's important that you have to see and plan your surgery before you jump into and taking a knife. And that's my new center. It's been 1 year, and that's my team, and that's Dr. Indrajit with me. Thank you.